pain, and Fugax means kind of like fleeting. It comes and it goes. The pathophysiology is basically spasm, contraction of the anal sphincter. So you can get spasms, contraction, and this is gonna be due to some sort of pudendal nerve damage. It's more common in the female. Not sure why. Maybe it's because of their delivery. And it's gonna be associated with irritable bowel syndrome, IBS, psychological stress, anxiety. We can have manifestations are gonna be recurrent rectal pain, unrelated to defecation. We're gonna have the episodes last usually 30 seconds, no pain between episodes. So we're gonna give them reinsurance, give them nitroglycerin, and we're gonna biofeedback. All right, so we have our proctitis over here, so radiation proctitis. But before that, we have a question over here. 76-year-old male rectal discomfort worsened for the past 3 days. Anal area shows thick protruding rectal mucosa mass with bluish discoloration and constant ring. What's the next step? We should do surgery over here. This is a emergency which we're going to speak about in the next page, which is going to be prolapse. Okay, we have over here acute radiation, which does mean less than 2 months, or does it mean less than 8 weeks, and then we have chronic radiation prognosis will be more than 3 months. So this means mucous damage, so diarrhea, mucosal discharge, tenesmus. So tenesmus is the feeling that you need to pass stools even though your bowels are already empty. Okay, so there's going to be the need to pass stools even though your bowels are already empty. So that's going to be okay. Then we can see manifest the endoscopic appearance is going to be like edema, and ulcerations, and we can have also antidiarrheals, as we spoke about in my second last video, which was about microscopic light. I didn't release that video, so that was about microscopic lights where we give budesonide. We can give antidiarrheals as loperamide, and we can give butyryl enemas as well. Chronic proctitis more than 3 months to years. It can be obliterative enteritis, ischemia, fibrosis, severe bleeding. We can multitelein ectasias. We can give steroids over here, so thermal coagulation, and we can give steroids. Coming to the next page, rectal prolapse. So this is going to be a woman above the age of 40 with history of vaginal deliveries, multi-parity. We can see prior pelvic surgery is going to be another risk factor. Constipation, diarrhea. We can see the diarrhea, straining, stroke, dementia, pelvic floor dysfunction, anatomic defects. This is going to present as abdominal discomfort, straining, or incomplete bowel evacuation, fecal incontinence. We can see digital maneuvers supposedly required for defecation, erythematous mass extending through the anus, concentric rings, full nictus prolapse, and radial invagination and thickness prolapse. Management is going to be medical, so consider non-full thickness prolapse, so adequate fiber of fluid intake, pelvic floor muscle exercises. And we can see possible biofeedback therapy for fecal incontinence. That's going to be biofeedback is a non-invasive technique that helps patients with fecal incontinence by training them to improve awareness, improve their pelvic floor muscles in fecal incontinence. So we can see rectal prolapse. What's the treatment of a 3 centimeter prolapse with concentric rings? We could do surgery, or as we have spoken about, we can do biofeedback. I'm going to go with surgery over here. Surgery is the answer. Okay, we can see the mucosa, we can see the mucosa over here, the anal sphincter, and we can see the rectum. So we can see part of the rectum, the mucosa peritoneum is coming through over here, and full thickness prolapse over here. So we can see a protruding mucosa with radial invaginations, erythematous mass with concentric rings. Okay, anal fissures. We can see over here what's the cause of pain, and the bright red blood per rectum. That's going to be your anal fissure. Okay, so anal fissure is going to be why this is over here. I want to speak about this. Okay, anal fissures are small tears or cuts in the anal drum. This area is highly vascular and is especially supplied by the inferior rectal artery and is not keratinized. Making it fragile or prone to bleeding. This causes fresh bleeding. They are located below the dentate line, where the bleeding in the epithelium is skin-like squamous epithelium and pain sensitive. Because of this, they are likely to rupture or bleed spontaneously. Alright guys, I want to speak to you guys about Proctalgia Fugax. Proctalgia means Proct essentially means your rectum. Algia means pain. Fugax means that's fleeting and coming. It's more commonly seen in women. Maybe that's because of the delivery system. It's going to be pain that's not with the defecation. So that's going to be pain not with your defecation. Treatment is going to be nitroglycerin. We can maybe give some nifedipine. Not too sure about that one. We can maybe give some lidocaine, but there's going to be more like biofeedback therapy. So that's going to be the treatment over here. That's coming to proctitis. This is going to be your rectal, it's going to be acute and your chronic. So acute is going to be less than 2 months. Essentially, you're going to get diarrhea, mucus, tenesmus. Tenesmus, essentially, you cannot empty your bowels. And I mean, you cannot do, sorry, tenesmus is a feeling that you need to pass stools even though your bowels are already empty. So that's what's going to be here. So that's me tenesmus. We can give this antidiarrheals, some enemas just to kind of slow it down there. Chronic radial proctitis is going to be more than 3 months to a year. Fibrosis is going to be severe amount of bleeding, and the management is going to be we're going to be giving like steroids. We can be giving all this type of good stuff, and thermal coagulation. That's something I forgot. Okay, we can give sucralfate. Sucralfate is bismuth. Bismuth and sucralfate are these really cool laxatives essentially. So they are going to be sucrosulfate that binds to the proteins in the ulcers, adheres to the surface ulcer area. So really good. So bismuth, sucralfate, excellent drug for treating your ulcers. We can give rectal prolapse over here. Rectal prolapse is going to be when we're going to be having constipation, any sort of problem like that, and we're going to be having abdominal discomfort, fecal incontinence, and digital tubes are required for defecation. Okay, and there's going to be concentric rings, essentially, or rings or radial invaginations, non-full thickness prolapse over here. Medication is going to be considered non-full thickness prolapse. We can see the adequate fiber and fluid intake, pelvic floor muscle exercises, possible biofeedback therapy. Surgery for full thickness and debilitating symptoms is going to be fecal incontinence, constipation, and sensation of mass. So we can see this over here. And guys, recall that anal fissures or small tears, this area is very vascularized, okay? Especially the inferior rectal artery, okay? Your inferior rectal artery, it will, I believe, it drains into internal pudendal artery, okay? And that which would then drain into your internal iliac artery. Let me just check this all out. But that's going to be the drainage system, which I'm correct about. And this will lead to a fragile, prone to bleeding, and this below the dentate line, okay? That's where the squamous epithelium is. So this is pain sensitive, okay? So it's really painful and bright red blood per rectum, okay? So we found this video. Hope to see you guys next time.